we try to address a lot of needs through a very medical system. As a doctor, you have to accept with humility that a social worker or a community health worker may be better able to get to the heart of the issue for some problems and be able to deal with it more effectively than I can. In fact, it doesn't need a MD level of expertise, and in fact, being an MD is kind of an impediment to really dealing with it effectively.
Okay, so basically our outreach teams that are in the community, some of them are embedded within a few primary care practices across the city. So we not only are providing this enhanced primary care coordination service to the practice, but we're also at the same time looking at the various workflows that they already have in place, what their administration is like, and sort of facilitating that practice transformation at the back end as well, so that once we're ready to hand patients off to the primary care practice, there are adequate workflows in place that accommodate really complex patients like the ones that you saw examples of this morning. So a day in the life of somebody who works on an outreach team like that is basically, depending on what stage of sort of the patient is at, either they get a nursing heavy support or they get health coach, community health worker heavy support.
When this project is successful, it is empowering the primary care providers and their offices to be able to provide this level of management to their patients. So I think the ultimate goal is that at the end of the 5 years, we'll be able to walk away, and the offices that we're working with will have the infrastructure that we help build will stay supported. And so our intervention will be integrated into the staff that they have and to the kind of care that they give.
So they met weekly, and we applied for some grants, and Dr. Brenner and Dr. Steve Kaufman were able to get a grant that allowed for a more comprehensive approach to diabetes care in Camden. And it includes these classes, it includes working with the providers so that they have a more consistent approach to managing diabetes. We also have developed a way for all of the educators in Camden to get together so that we use the same techniques and the same strategies, the same approaches to working with the patients. So when we started, there was maybe two and a half people working in, I know there's not possible to have a half a person, but time-wise, 2 people and maybe a half-time person working in the city of Camden with diabetes education. Now, every month we get together, and there are 10 to 12 of us, and we share information, we share how we teach, we talk about changes in how to approach it. So we've worked on motivational interviewing, we've worked on using AAD7 behavior change. So we're supporting each other to do good work in Camden.
Typically, the way that our workflows work is that for the first portion of patients' interaction with us, they get a lot of clinical support around the medication, reconciliation, helping them to stabilize their meds, figuring out what those clinical goals are. And then with regards to the ongoing support, they get that then from health coaching, and sort of those folks help to coach them to self-advocacy, teaching them how to negotiate, what their agenda is with their primary care provider, teaching them how to communicate with, the pharmacy, who do you call when you really have to go to the hospital. You don't have to always, you can call the provider first. You don't have to go to the emergency department immediately. So sort of coaching folks through all of those steps. How do you access transportation? I mean, folks with limited, language proficiency and literacy, they have all of these challenges on the daily. I mean, even with regards to their medications, what the dosages are, it's really hard. Like, there's not enough teach backs that happen. So our team really provides that wraparound support when somebody is newly diagnosed or has been diagnosed for a few years but hasn't had that level of support that they really would need to really understand how to manage their chronic disease.
We had a gentleman in the class who had very high A1C, and so I'm just going to tell you, I'm going to use the word lovely gentleman. I mean, as soon as I met him, I knew that this is a man who has wonderful friends, is a good person, and his A1C, he was moving in the direction of needing an amputation or dialysis or having a heart attack. He would not take insulin. And so it's an example of one person, but I see it all the time. This class helps a person start taking insulin. As soon as they take the insulin, their A1C gets closer to 7 or below 7, which is our target, and you can see the difference. And I think that's how we're saving lives. We're saving lives by helping people see that they can take insulin, and it's good.
So the goal is, if we say there are things in the system that are not paid for and not getting done that patients really need, if we can demonstrate that that's what's really needed and it actually saves money in the long run, then we can advocate for them to be paid for. We can advocate for systems change that puts in place what's really needed.